Good afternoon, everyone. First of all, I'd like to thank Dr. Monreal for his kind invitation. It's a great honor to be here in this first international RIETE meeting. I didn't know how to focus my presentation until my son asked me a question the other day. And of course, I had no choice. I had to tell him the history of the ugly duckling. When we want to answer this question, we realize that retinal vein thrombosis is a real ugly duckling of thrombosis. And we can see very well in the line when we look and see that there are 700 meta-analyses for DVT, 400 for pulmonary embolies, and only 28 for retinal vein thrombosis, and most of them of intraocular treatment. And in the ACCP guidelines, what about retinal thrombosis? Nothing at all. Before continuing looking for answers, I'd like to tell you some questions about retinal vein thrombosis, right now called retinal vein occlusion. We include this thrombosis and unusual side vein thrombosis. It's a common cause of visual loss in people over 50 years. It's the second retinal vascular disorder following diabetic retinopathy. The average age was 60 years, no gender differences, and the prevalence is about 0.5% in general world population and increased to 5% in people aged 80 years or above. It's estimated to affect 16 million people worldwide. The major morbidity is blindness, which is given by macular edema, macular ischemia, and neovascular glaucoma. Regarding treatment, there is one local which is changing a lot in the recent years, mainly by intraocular injection of antivascular endothelial growth factor. And there is one systemic treatment unchanged in the last 20 years. From an anatomical point of view, we can classify them in central, hemicentral, and branch retinal vein thrombosis. The branch retinal thrombosis is 4 times more common than central. You can see in the slide, artery and veins coexist in a tight space, sharing adventitious and glial disc. This is the most important for understanding the pathophysiology, where the artery is the main protagonist that cause an increase in size or consistency of the artery and lead to narrowing the vein and slowing the blood flow, both prothrombotic conditions. This alters vessel wall, activate different inflammatory mediators, impair blood retinal barrier, increase vascular permeability, macular edema, ischemia, and decrease visual acuity. What known the predisposing factors, in addition that the direct trauma that Mourinho showed us a few years ago, is mainly associated with age and a cardiovascular risk factor, especially hypertension. What about the prognosis? Some actors associate this thrombosis to high risk to vascular disease and increase to mortality for this reason. The results are different, and there is a contradictory result about it. There is the latest about it. According to this meta-analysis of 6 studies involving 549 patients, they present increased cardiovascular mortality like intermediate risk factor at the expense as a stroke in male smokers. In this study comparing 459 patients with central retinal vein occlusion with 2,000 controls shows a greater mortality for cardiovascular event. Before continuing, I'd like to ask a question. One 55-year-old male with retinal vein thrombosis, I wonder how many of you will treat this patient with anticoagulants. Can you raise your hands, please? Well, I was so clear because today, after 100 patients, I have not so clear, and I have not anticoagulating any of them. When we search the answer to this question, in Medline, retinal vein thrombosis and anticoagulation, there are only 4 studies, and we found only 1 study interesting for us. Which are the most impacting articles about it? This is American retrospective study compare retinal vein occlusion anticoagulate for another reason with retinal vein occlusion not anticoagulate. The visual acuity and retinal perfusion data were similar in both groups. It's possible anticoagulation could be not useful in these patients. This Australian meta-analysis about retinal vein occlusion and treatment with more than 3,000 publications and 17 randomized clinical trials found no conclusive results in systemic treatment. This Dutch study about retinal vein occlusion and thrombophilia only found association with hyperhomocystinemia and anticardiolipin antibodies. This shows once again the role of the artery disease. This Italian meta-analysis about retinal vein occlusion and low molecular weight heparin and compared with aspirin shows better visual acuity and less ocular adverse events with low molecular weight heparin without increased hemorrhage. What is the problem? They compare with aspirin, and right now aspirin, according to the guidelines, is not recommended for primary prevention in this patient unless there is another reason to indicate. Well, there are many publications, some one very interesting like this about Football World Cup in 2014, but it's time to move to the RIETE wall. When we analyze the RIETE wall, we analyze 65,000 patients, 15,000 with DVT, and only 246 for retinal vein occlusion. When we compare both groups, highlighted cardiovascular risk factor, mainly hypertension, dyslipidemia, and diabetes. Curiously, there is no differences in the target organ injured, and the risk factor for venous thromboembolism only knows that 92% were hepatic. Curiously, there is no differences in hyperhomocystinemia, antiphospholipid, and thrombophilia results. Regarding initial treatment, in the retinal vein occlusion group, there is only 6% received low molecular weight heparin, and 83% were not treated with anticoagulants. In the long-term treatment, the retinal vein occlusion, only 6% received vitamin A antagonist, and 2% drugs, 28% antiplatelet therapy, and 60% were not treated. The clinical outcomes are better in the anticoagulation group, but the sample is very small, but perhaps these results suggest that anticoagulation could be useful in these patients. To conclude, what to do the next? Well, it's essential right now to systemic assessment where identify and treat cardiovascular risk factors. There is scientific evidence to should be studied homocysteine and antiphospholipid. Many doubts in thrombophilia and systemic treatment. There is no evidence in anticoagulation or aspirin therapy, although the result of the RIETE results suggest that anticoagulation could be useful. Low molecular weight heparin can be useful according to one meta-analysis. And finally, the most important, we have an obligation to help resolve all these questions with our most powerful tool, RIETE. So from here, I ask you to include this patient in RIETE. Here ends the history of the early diagnosis of thrombosis Thank you for your attention.
I want to congratulate the speakers because of these their excellent presentations. And now we have enough time for making questions. I invite the speakers to come here to the table, please. And we can begin the round of questions. Dr. Brenner, the microphone, please.
The question is to Dr. Rosa. Thank you very much for your beautiful presentation.
The question is to Dr. Rosa. Thank you very much for a beautiful presentation. I think you mentioned in the beginning that it's actually very common. But in RIETE we have so few, so this is actually a very, very small sample, probably biased. And do we know how biased? Are there specific centers or that look for these patients, or do we need to do something because we don't see this kind of patient because the ophthalmologists actually see them? I remember in the 90s when thrombophilia was in, then they sent us many patients to look for thrombophilia. I'm a hematologist, but now since thrombophilia now is going down, we see less this patient. And this is a general question to diseases which are not the regular one that we see like DVT in the leg or PE, because we should think of how we could increase the recruitment of such diseases. And this is a question maybe to the panel, to RIETE.
Thank you for your question. Well, I think that the main problem in the retinal vein occlusion, in my experience, I don't study the thrombophilia. Because when you get the result of the thrombophilia in DVT or pulmonary embolism, this condition, the duration of the anticoagulation. But right now, the anticoagulation, there is no evidence with the treatment in the retinal vein occlusion. In my practice, not change my treatment in this patient. It's for that I don't study the thrombophilia. Different the result of this meta-analysis, because not change my management of this patient. I think is the most important is multidisciplinary management with ophthalmologists. Okay, and I think the RIETE is the beginning to future studies with, in our case, with low molecular weight in the initial treatment to improve the results. In my patient, there is not clinical outcome with DVT or pulmonary embolism, but in the RIETE, there is some patient with DVT or pulmonary embolism. I think I need a big sample to improve the results.
From my Italian colleague Antonella Tufano, it may seem a stupid observation, but it's not as stupid as it may seem. The abbreviation SVT has not been defined to define superficial vein thrombosis of the legs. And it makes confusion. Also to me, the first time I read a paper dealing with SVT, I intended the paper dealing with superficial vein thrombosis of the legs and not splantary vein thrombosis. So in my opinion, there is an urgent need to modify this abbreviation in something else. SP, for example, VT, splantary vein thrombosis, because it may really generate confusion for readers.
Yes, I agree with you, Professor Condoit. But in some studies I found this acronym SVT, in other not. For example, in the ACCP guideline they don't use SVT as an acronym, while SPVT is usually used for splenic vein thrombosis. So we need another name for this venous thrombosis. I don't know which can be.
Thank you. I would like to highlight the relevance of this roundtable because we experts on treating patients with VTE are used to assist to congresses, to meetings, national, international, and the focus is mainly focused on pulmonary embolism and deep vein thrombosis in the lower or upper extremities, but a roundtable containing topics as retinal vein thrombosis, superficial vein thrombosis, splenic vein thrombosis. This is a quite unusual roundtable, and the results that have been shown clearly demonstrate that we should move to focus our interest too on these unusual forms of venous thrombosis. Maria tells us that patients with only superficial vein thrombosis, these patients are usually in many hospitals referred to the vascular surgeons. To treat these patients with a 2-week 15-30 days of therapy, most often with a